Hello, I'm Dr. Ira Chasnoff. Welcome to my class on opiates, methamphetamine, and cocaine, changes in brain functioning in the prenatally exposed child. In this class, we're going to look at the biological basis of the effects of prenatal drug use on the catecholamine system, how those changes in the catecholamine system of the fetal brain translate into behavioral difficulties with the child who was prenatally exposed, and look across the spectrum of behavioral functioning, neurocognitive, self-regulation, and adaptive functioning. To best understand this, we have to understand how our nervous system works. So let's just take an easy example. Let's say I want my fingers to wiggle. Now, there's not one long nerve from my brain to my fingers to tell them to wiggle, but it's a series of nerves. The electrical message I send from my brain must travel down the nerve pathway, but when it gets to the end of one nerve, that electrical message has to cross over to the next nerve. The way that happens is through the neurotransmitter system, the catecholamines. Now, you've heard of the catecholamines. There's serotonin, there's norepinephrine, and the topic of our discussion today, dopamine. So here's what happens. I send an electrical message from my brain to my fingers to wiggle. The electrical message travels along the nerve pathway, is picked up by the dopamine receptors, carried across the nerve gap to the distal nerve ending, and releases the electrical stimulus. So the dopamine has done its job. The dopamine then circulates back to the first nerve ending. That's called reuptake. So through dopamine neurotransmission of the electrical stimulus, release, and then dopamine reuptake, that's how I control how long my fingers wiggle. Because through dopamine reuptake, I stop the signal. That's all well and good. However, dopamine is also the pleasure center of the brain. So, if you were to take a break from this class and go get a bite of food, food raises dopamine levels 125%. That's why we like to eat. It makes us feel good. Now, if you were to go out and smoke a cigarette, nicotine raises dopamine levels 200%. Cocaine, opiates, raise dopamine levels 300%, and methamphetamine raises dopamine levels 1,000%. So that's why folks use drugs, is to get that dopamine blast. And you can see, especially with methamphetamine, how it would produce this enormous high from this blast of dopamine. Now, the various drugs act in a variety of ways. For example, methamphetamine causes massive release of dopamine across the nerve gap. With cocaine, there's a normal amount of dopamine that crosses the nerve gap, but as the dopamine circulates back, that is the reuptake process, cocaine blocks dopamine reuptake. So what you get is buildup of high levels of dopamine at the distal nerve ending. And again, this is what produces the high. Now, opiates' actions on the dopamine receptor system are a little more complicated. There are in the brain 3 types of neurons that participate in opiate action. Opiates, represented here as the green molecules, attach to the opiate receptors, which are indicated by the yellow colors. When opiates do bind to the opiate receptors, this decreases GABA. GABA inhibits dopamine release. This sends a signal to the dopamine terminal to release more dopamine. So again, you get high levels of dopamine. It's really not necessary to understand the actions of each of the drugs. Just be aware that no matter what drug you're talking about, whether it's nicotine, marijuana, cocaine, methamphetamine, they all act on the dopamine receptor system to produce higher levels of dopamine. That's what produces the high. Now, this affects the way the dopamine system functions. And to really understand the impact on behavior, let's talk about information processing. Now, what is information processing? Information processing is the way information enters the brain, and the brain organizes that information, stores it in memory, and then uses the information to guide language, motor skills, other activities throughout the day. So there are 4 steps. Input, which is bringing information into the brain. Integration, which is organizing the information. Memory, which is storing the information for later use. And then output. How do you use that information appropriately? So let's take an easy example. Let's say I turn to you and ask you, there are a big pile of books out in the lobby out there. I need you to gather up those books, bring them in the room, organize them, so if I ask you for a book, you can give it to me. You say, sure. So you go out into the lobby, you gather up the books and bring them into the room. That's input. You then organize them probably alphabetically. That's integration. You put them up on the bookshelves. That's memory. And then if I ask you for green eggs and ham, you go to S for Dr. Seuss and hand me the book. That's output. Now here are the basic areas of the brain. There's the frontal lobe, way up front, and the frontal lobe contains the prefrontal cortex. Now why is the prefrontal cortex important? Because that's where dopamine is located. That's why the prefrontal cortex is the regulatory center of the brain, because it does contain dopamine. There's the parietal lobe at the upper back part of the brain. There's the occipital lobe at the very back of the brain. And then, of course, the temporal lobe on the sides. Now, you don't necessarily need to know the different parts of the brain, but here's what you need to understand. Any information that enters your brain enters through different pathways. So all visual information enters the eye, travels the entire length of the brain via the optic nerve to hit the back of the brain where the visual cortex is located. So you actually see with the back of your brain. Anything you hear enters the ear, travels along the auditory nerve, and enters the midline of the brain, and taste, touch, and smell enter the parietal lobe. The job of the brain is to take this information from the different pathways and integrate it. And I'm sure many of you have heard of sensory integration. So the information is integrated, stored in memory, and when you need that information, it shoots forward to the prefrontal cortex, which contains dopamine. The dopamine then fires off and tells you how to respond. A simple example, let's say you take a break and you're walking along the sidewalk. You come to a street. What do? You look to see if a car is coming. The image of the car enters your eye, travels along the optic nerve, and hits the visual cortex. Flash, there's the car. That image shoots forward to the prefrontal cortex, where dopamine fires off and says, stop walking. That's called motor regulation. All activities through the day are regulated through this type of system, through the dopamine receptor system. So let's get back to the drugs now. What complication do we see? As I said, dopamine is not only the regulatory center, but it is the pleasure center of the brain. Methamphetamine causes massive release of dopamine across the nerve gap. But what happens over time is you begin to deplete your dopamine receptors. With cocaine, there's a normal amount of dopamine that crosses the nerve gap, but cocaine blocks dopamine reuptake. So what you get is a buildup of dopamine at the distal nerve ending, produces the high. Now we could go through every drug you can talk about, any drug you want to name, and we can look at the effects of that drug on the dopamine receptor and show you the depletion of the dopamine. What implications does that have? How do you feel when your dopamine levels are low? irritable, off task, can't focus, can't concentrate. It doesn't feel very good at all. And the only way to feel better is to get more dopamine going. And how do you do that? By using more drug. So that's what is referred to in the world of addiction as tolerance. It takes more and more of the drug to get what dopamine levels you need. Talk to anyone who's been through addiction, and they'll tell you, I started using drugs to feel good, but I kept using drugs so I wouldn't feel bad. Now, this is a PET scan. In a PET scan, what you do is you inject dye into the patient's bloodstream, and dopamine will pick up that dye. So what we see here on the left is a 22-year-old young man. We're looking down on his brain, and the yellow and red is dopamine. Those images with yellow and red represent the prefrontal cortex. Now, this young man went out and started using cocaine. And this is his PET scan on the right a year later. What you can see is that the dopamine is depleted. There's no yellow and red. And this is the effect of chronic drug use. That's what happens, but the good news is that if a person gets into recovery and stops using any of the drug, after about 14 to 24 months, the dopamine receptor system will begin to recover. And so if you do another PET scan, you'll see the yellow and red have reappeared. That's after 14 to 24 months. However, the dopamine levels never reached the level they were before the person started using drugs. So that's why, again, in the world of addiction, folks don't say, I'm recovered. They say, I'm in recovery. But at least that's the good news. There is some recovery of the dopamine receptor system. Now, pertinent to our topic today, what about infants prenatally exposed to these substances? Well, obviously, we can't do these studies in human babies, and so we turn to animal studies. And these animal studies have been done in rats, in sheep, in monkeys. So let's talk about rats. Rat brains are very similar to human brains physiologically. So if you give any of these drugs, whether it's nicotine or cocaine, you name it, any of these drugs to a pregnant rat, you do a PET scan on the baby rat at birth, what do you see? You see the PET scan similar to the one on your right. Depletion of the dopamine receptors. You then let these baby rats grow into teenage rats, and what do you see? The same thing. And then let them grow into adult rats. Again, you see the same thing. So what we know from the animal studies is that the prenatally exposed fetus is born and then grows into a teenager, into an adult, with depletion of the dopamine receptors. Again, I caution you, these studies have not been done in humans. However, if you think about children who are prenatally exposed to opiates, methamphetamine, cocaine, etc., one of the most common diagnoses made in these children is attention deficit hyperactivity disorder, ADHD, or attention deficit disorder, ADD. In any case, let's talk about children with no exposure. So step back now from the world of drug use, and let's just talk about normal, everyday children in the United States. By far, the most common diagnosis in children is ADD or ADHD. And what's the cause of that? It's a genetic trait inherited from either their mother or father. One of the parents had ADD, ADHD, and now the child does too because they have low levels of dopamine. And what do doctors give children with ADD, ADHD? They give them something like Ritalin. What is Ritalin? It's an amphetamine. What do amphetamines do? Release dopamine. So you can see that children with genetically inherited ADD or ADHD, it's all based on the dopamine receptor system. Now we turn back to our children with prenatal exposures, and yes, by far the most common diagnosis among them. In fact, in studies, up to about 74% of children with prenatal drug exposure do meet criteria for ADD or ADHD. Now, how does that show up across the lifespan? First, let's talk about the infant. And we look at infants from the perspective of neurobehavior. What is neurobehavior? Neurobehavior is the way that we as humans relate to and interact with the world around us. It's a response to our internal and external environment. In our clinical work, we evaluate infants from the perspective of neonatal neurobehavior. And we look at 7 domains of functioning, but I'm going to talk about only 2 of them, the 2 that most apparently are affected by prenatal drug exposure: orientation and state regulation. Now, what is orientation? Orientation is the way we interact with and respond to the stimuli around us. So for a newborn infant, starting as early as 24 hours of age through 1 month of age, you have the infant lying in a crib on his back, and you ring a bell, or you speak to the infant. You give them auditory stimulation. The infant will show a learning response, and then typical normal infants will turn their eyes or maybe their head toward your voice or toward the bell. And you go to the other side of the infant, you do the same thing. The infant will orient toward your voice or the bell. This is called auditory orientation. Then the next step is you take a red or yellow ball and hold it about 18 inches in front of the infant's face. And you will see that he'll actually focus. He'll look at that ball. You then give him your face, and the infant will respond to your face. As early as 24 hours of age, he will show orientation toward these visual stimuli. Now, in an infant with prenatal exposure to any of these drugs we're talking about, when you ring that bell, or when you talk to the infant will show alerting responses, but then he doesn't know which way to turn. So he cannot orient toward the auditory stimulation. And in fact, if you keep trying to get him to listen to you, he'll begin to escalate in his behaviors. As for visual orientation, it's the same kind of thing. If you hold that red or yellow ball in front of the infant, or if you give him your face, he may glance, but he's going to move away very quickly. This is called gaze aversion. He cannot hold your gaze. In fact, the human face is very overstimulating for these infants. If, in fact, you keep trying to get him to orient toward your voice, toward your face, he's going to begin to escalate and very rapidly will become very irritable. And this is where we talk about state regulation, the ability to regulate state of arousal. In a normal newborn infant, they may be quiet and sleeping, will begin to awaken, reach an alert responsive state, and may escalate to crying. But infants have self-soothing behaviors. They'll bring their hands to the midline. They may rock their head. They'll bring their legs up into the midline. They may even suck on their hands. This is self-soothing behavior. And what you'll watch is the babies will make smooth transitions between levels of arousal. However, in infants exposed to any of these substances, including, let me mention here, including marijuana, these infants will be quiet and sleeping, will begin to awaken, and then they will escalate very rapidly to crying and irritability, and just as rapidly may drop down to a deep sleep again. So they have very erratic regulatory abilities when it comes to state of arousal. It's what I call yo-yo behavior. The infants are just bouncing up and down, and so it's very hard for new parents to know how to interact and respond to this infant. As we move from infancy to early childhood, we see the continuing effect of regulatory difficulties. These regulatory difficulties are expressed in the young infant through problems with sleep, because sleep is a regulatory activity, with habituation, the ability to block out negative stimuli. As you participate in this class today, there may be other things going on around you. There may be a bell ringing, door slamming, other people talking, but your dopamine system is firing off, helping you focus to block out negative stimuli. That's called habituation. Babies with prenatal exposure have very poor self-soothing behaviors, cannot attend to stimuli, have very difficult transitions between states of arousal and between activities, have difficulty modulating their affect. And a classic example is during the snowy winter, a mother comes in, her 2-year-old is sitting on the floor playing. She comes in, sweeps him up, gets him into his snowsuit, and then puts him in his car seat because they have to go pick up the older child at school. Well, those kinds of rapid changes in activity don't sit well with the prenatally exposed child. And so we have to work with parents on how to make smooth transitions between one activity and another. Now, as we look at behavior in older children, in teens, and young adults, we consider their behavior across 3 domains of functioning: neurocognitive, self-regulation, and adaptive functioning. Now, I'm going to go through each of these domains of behavior and talk specifically about the behaviors that are affected by prenatal drug exposure. So let's consider neurocognitive functioning first. Global cognition falls into the domain of neurocognitive functioning, and I mention it here to emphasize that global cognition, that is IQ, global developmental scores, are normal in children with prenatal drug exposure. So let me say again, prenatal cocaine, methamphetamine, opiate, marijuana exposure do not affect global cognition in and of themselves. Now, if there's an accident at birth, of course, such as an abruption, if the child has something happen, he has cerebral palsy, it can affect the child's global cognition. However, it's important to understand that global IQ, global developmental scores are going to be normal. The area of neurocognitive functioning that is most affected by prenatal drug exposure is executive functioning. Now, what is executive functioning? Executive functioning is the ability to plan and complete a task. It's how our brain uses information to plan ahead, to know the consequences of our behavior, to sequence. Let me give you an easy example. Now, we're going to have a little, we're going to play a game here. I'm thinking of a number between 1 and 1,000. I want you to ask me a question that will help you figure out what number I'm thinking of. Now, the majority of you, the most common first question is it above 500 or is it below 500? And if I say yes, it's above 500, for example, what's the next most common question? Is it above 750? And I say no. So what your brain now realizes is the number is between 500 and 750. So this process, you would continue asking questions that could be answered yes or no, and it would narrow your options until you find out what the number is. That's a good example of executive functioning. Now, every part of your brain is involved in executive functioning. Long-term memory, short-term memory, transitioning. So what you're doing is you're working, you're planning, and you're moving toward your final accomplishment of the task, finding out what the number is. That's executive functioning. Another example, if you have an early morning meeting, what do you do the night before? You think, well, I have to get to that meeting by 9 o'clock. That means I have to leave the house by 8:30. Now, I want to shower first, that's 15 minutes. I want to eat some Cheerios first, that's another 15 minutes. So what you do is you move back the time. You have to be there at 9 o'clock. You move back the time it's going to take you to get ready and to show up on time, and you set your alarm clock at the appropriate time. That's executive functioning. So you can see how executive functioning is so important to our daily lives. It is by far the most common deficit seen in children with prenatal drug exposures. Problems with executive functioning. The second domain is self-regulation. And this is the domain that is most often recognized. It's the ability to regulate motor behavior, its impulse control, its emotional regulation, and its sensory processing. And in our studies, for drug-exposed children, the most common deficit is executive functioning, and the second most common deficit is in sensory processing. What is sensory processing? Sensory processing is taking the information in, and it's that aspect of integrating the information, making sense of it. Some children need lots of stimulation, lots of sensory input to function. Some children are sensory avoidant, that is, they can't tolerate much sensory input. But whichever way, it's going to affect their behavior. In a study we published on misdiagnosis, so many of the children that were referred to us with a diagnosis of ADD or ADHD, in fact, did not meet criteria for the attention problems, but did have difficulties with sensory processing. And once we got them into sensory integration therapy and improved their sensory processing, they did not need medications for ADD or ADHD. So it's important to really look beyond the behaviors we see to understand what's going on in the child's brain. And of course, all of this is because of deficits in the dopamine receptor system. That's why, instead of necessarily using DSM-5 diagnoses to guide our evaluations, we look at the children's behaviors from a regulatory perspective. How are they able to regulate their motor behavior, their emotional functioning, their thinking, their planning? And if you do that, you will decrease the number of children who are actually on medication and increase the number of children that you're providing treatment to. That's why we have to look beyond the behaviors we see to understand what's really going on in the child's brain. We look at the children not from a developmental, not from a behavioral perspective per se, but from the perspective of self-regulation. How are they able to regulate their motor behaviors, regulate their emotions, regulate their thinking through tasks? If we look at them from the perspective of self-regulation, we will get more accurate diagnoses, a better understanding of what's really happening with the child, and we also will be able to decrease the use of medications and increase the behavioral and treatment approaches that we use with this population of children. A third domain is adaptive functioning, but adaptive functioning is not affected by prenatal drug exposure. Adaptive functioning deficits are characteristic of children with prenatal alcohol exposure. I include it in this class, though, because often we get a child referred to us in our clinics with a note that the child was prenatally exposed to opiates or to methamphetamine or to cocaine. The illicit drugs, the marijuana may be mentioned, but most often we do not get the information that the child was exposed to alcohol. If we see a child in our clinic who has documented exposure to cocaine, methamphetamine, any of these other drugs, but as we evaluate the child, we find that adaptive functioning is affected, there is a deficit in adaptive functioning, we know from a clinical perspective that this child in fact was exposed to alcohol. Now, in those cases, if there's no documentation of the alcohol exposure, we cannot make a diagnosis within the fetal alcohol spectrum, but it plays into our plan as to how we're going to approach treatment of this child over the long term. So what I've tried to do in this class is give you information as to the biological effects of the illicit drugs, of marijuana, of nicotine, on the dopamine receptor system, the importance of the dopamine receptor system in regulatory behaviors, and how deficits in regulatory behaviors show up in the child as he grows from infancy to childhood to the teen years into adulthood. Thank you for joining us for this class. If you want more information, have a look at Sac County Healthy Beginnings website or at our website, NTI Upstream.